So hi everyone, welcome to the webinar. My name is Nick Boyce. I'm with the Ontario HIV and Substance Use Training Program, and this is the part 2 of our methamphetamine webinar. Some of you may have attended part 1 last week. We will be sending the slides from last week and today, as well as the recordings of the webinars following today, so we'll probably get that stuff out to you next week. Okay. Yeah, you're muted. Okay. All right. So let's dive right in. It looks like we got a variety of people on the phone. We're going to do some introductions in a minute. Just before we get going, for folks that haven't used this platform before, a couple of things to note. So you will be able to see who is on the call, on the webinar in the top right corner there. If you see someone you want to say hi to, you can hover your mouse over someone's name and enable a private chat with that person. If you have any questions or concerns, look for Francisco Sapp or Kim Trenchard. They're working busily in the background here, keeping an eye on things, so you can connect with them and do a private chat with them. If you'd like to contribute to the discussion, that's in the left here, so you can put your questions in there. We'll keep an eye on the questions. We'll try and answer some as we go, but we might leave some until the end. And if you want to also get our attention, another way to do that is at the top of the page there, you'll see a little icon with a hand up. You can drop down and raise your hand. That'll get our attention as well. And then finally, in the bottom right corner, you'll see all the resources that we'll be mentioning. So you can download those starting right now, and we'll touch on those as we go. Some of those are the same resources that we provided last week in part 1. So you may have seen some of those already if you were already on the call. I just have to apologize. I am feeling pretty sick and have a sore throat and a headache, so bear with me. I'll be probably taking lots of sips of water. And if it becomes hard to hear us, I'm going to introduce others on the webinar in a minute. Just let us know. So one thing we did want to announce, and if you were on the call last week, you will have heard this, but the Ontario HIV and Substance Use Training Program is now refocusing our work in conjunction with our funder at the ministry. We are renaming the program, refocusing our work. You can go on our new website to learn more about that. I'm not going to get into all of the details now, but just to let you know that we will, moving forward, now be known as the Ontario Harm Reduction Network. This is our new logo here, and we have a new website coming, and we'll be sending out a formal announcement within the next week around that. So on that note, we're going to start the webinar as OHRN, or the Ontario Harm Reduction Network. So again, this is part 2. Last week was part 1. So last week we really looked at the basics of methamphetamine. We sort of looked at the history of meth a bit, looked at the pharmacology and the physical effects of the drug in the body. We talked a little bit about how it was used, and we had someone, Colin Johnson, on the line who uses it to talk about how he smokes it. We looked at some of the equipment. And we looked at some basic risk and harm reduction strategies. Today we're going to go a little more in depth in terms of supporting and working with people who use. So we're going to touch on how to recognize and respond to overdose. We're going to be sharing how to engage with people that are coming into our agencies that may be intoxicated. And we'll briefly touch on some of the supports out there that are available for people out there. So we'll do some introductions and check-in. We'll get a sense of who else is on the line. We're going to touch on methamphetamine stigma before we get into anything else, and then we'll get into the overdose, the behavior piece, and then at the end we'll wrap up with some resources. And I've drawn heavily on a couple of presentations, one from the Addiction and Mental Health Ontario Conference last year, some folks local in Ontario, and then this resource here, which is in the download box from Australia. There's some really good stuff in there, so we'll reference those, but we've drawn heavily on some of the content from those documents. So with me here today, we have Brian Duresti and Sandra Kazazik, sorry, from St. Stephen's Community House. So do you guys want to just say hello and briefly what you do there?
I'm case manager, Brian Duresti. I'm harm reduction case manager at St. Stephen's.
I'm the drop-in coordinator at St. Stephen's Community House. We're a drop-in program that's serving population downtown Toronto, like primarily folks who are street involved, like frequently with mental health and substance use challenges.
And you see a lot of methamphetamine?
Yeah, so it's like one of the reasons we've kind of gotten involved with this is like over the last 2 years or so, we've seen kind of a significant increase in terms of crystal meth use, and then a lot of complications that come along with that, particularly in folks between 20 to 35. It's like they account for about, I'd say like half of our, more than a half of folks who access our space and use substances. So we've been dedicating quite a bit of our resources to kind of figuring out how to work with our folks in a more constructive way.
Okay. So we're going to be tag teaming a bit here throughout the day, and later on they're going to speak more specifically about how they've been working with clients at the drop-in there, and some really neat sort of engagement strategies and tips that they have for people to consider. So just before we get going though, I wanted to get a sense of who else is on the webinar with us today. So, oh, sorry, let me back up one here. How many people are on the webinar with you today? Is it just you at your computer screen, or is there more than one? Helps give us a sense of how many folks we're working with here today. Okay. We got a few groups of people too. That's good. Thank you. Okay. What region or LIN are you working in? And there are options for outside of Ontario, or you're not sure what your LIN is below. So the Ontario Harm Reduction Network has a provincial mandate. We work all across the province of Ontario, and we know in our travels and supporting frontline harm reduction workers around the province that there's been an awful lot of warranted attention around opioids the last little while, but there's not the only drugs, and increasingly we're getting asked about crystal meth as a drug that people are hungry for information about, and that was the impetus with these webinars. We have a mix of representation from across the province here. Okay. All right. Next one. In what field or setting do you work? So we've just created some broad categories there. Obviously you don't necessarily fit neatly into them, but if you could just sort of give us a sense of your primary area of work, helps us get a sense of who's on the call. Okay. All right, so we got lots of public health folks, it looks like, some frontline harm reduction workers, mental health folks. It's interesting the connections between crystal meth and mental health, and when is someone experiencing sort of mental health concerns, or is it drug induced? We'll get into some of that later. All right, so we got a mix of folks on the call, on the webinar today. Okay. Let me just see what else I have to do. What else in here? Okay. What was my next question for you guys? Okay, yeah. And then where you're working, do you offer services to homeless or street-involved clients? And there is a not applicable, maybe if you're doing maybe policy work or government stuff, maybe. So it looks like the vast majority of folks are working with similar clients to what you're seeing at St. Stephen's, likely. Okay. All right. Did you just do that? Okay. We looked at some of the evaluations from part one, and we actually ran these webinars earlier this summer, and we're just doing them again because there's a lot of interest. But some of the feedback we got after the part one webinar this summer, you'll see some of the comments here. So we had comments like more talk of the adverse symptoms, how to talk to someone while high to ensure safety. So we thought we had sort of expressed that we'd be doing that in part two. There were comments around focus on dealing with clients on meth. Again, that was going to be, and then this person thought that we were sort of glorifying drug use. And another comment around glorifying it or don't sensationalize it. That was not our intent at all. We thought it was very important to show the spectrum of meth use. That it's not just that there are people who can use it in a more recreational way, and because we can learn and compare and contrast from people that are using it and not struggling with those that are. So our intent was not to sensationalize it. And then there's this comment here around. I feel like they made it seem like meth wasn't such a bad thing, that it can be used recreationally. I haven't seen a lot of this in my work. So my comments around that's making us all chuckle here, but if we think about the type of work we're doing, who are we going to be seeing? And if there are people out there that are using meth recreationally, it's unlikely that they're coming in to access services because they don't need them. But this shapes what we see in our work, shapes what we think about drugs or people that use them and our approach to them. And there's a lot of sensationalism and stigma when it comes to methamphetamine, and in no way, I don't think any of us here are trying to minimize the serious concerns that some people develop when they're using methamphetamine. And Brian will actually be drawing on some of his personal experiences using to balance last week with Colin. Colin uses it in a non-problematic way. Brian's going to talk a bit more about some of the struggles he had with it. But we think it's really important that we represent both sides and figure out what we can learn from that. So today we will be focusing much more on people that do struggle with it and ways we can support those. So it was just an interesting thing, and I think it leads into the idea that there's a lot of stigma around methamphetamine. And stigma around any drug is often based in these stereotypes, which are often based on the more extreme or severe cases. We often see in the media the far cases because they make for good TV, or they sell newspapers. And again, working in this stuff, we're only going to see people that are already struggling. So this is important to think about when it comes to a concept known as drug set and setting, which we'll talk about later on, and then the connections between homelessness, trauma, and mental health as well. That stigma around methamphetamine then can be internalized by people that are using it, and that can make it very hard for people to talk openly and honestly about what they're doing. They may have a lot of shame and guilt around their use. They may not come in and talk to us. They may not be honest with us about what's going on in their lives, and then we can't have good, effective interactions with them. And as an example of some of the stigma around methamphetamine, some of you may have seen before these Faces of Meth campaigns, where they're sort of trying to discourage people from using by showing these scary pictures of people that are really in rough shape, and they say it's as a result of meth. I would argue that there's probably more going on in these people's lives than just methamphetamine use. And I'll come back later on to talk about these folks, some of the folks in these pictures here. Again, as we're going here, please jump in with comments or questions on the chat. Okay? And you guys jump in too if you want. So in terms of people's experiences and risks, and then overdose with methamphetamine, we have to, this is this concept of drug set and setting. It really helps inform how someone's going to react with any kind of drug use. And this has been core to any work I've done in harm reduction. There are these sort of three interrelating things. So what is it about the drug that people are using? So last week we learned that methamphetamine, for example, has a very long half-life. It lasts 12 hours in the body, and you've only removed half of it, versus cocaine, where it's a 2-hour half-life. So you'll see differences in the drug test. Some drugs are uppers and some are downers. Right? Then there's something about the person that's using it. So you might have a person using two different drugs. They're going to have different experiences because of the drug piece. Or you might have the same drug being used by two different people, but they have different experiences or risk factors because of the unique situations that they're in. What are some of the sort of common reasons that you've heard in terms of why people use methamphetamine?
Trauma is always number one for a lot of drugs, isn't it?
Yeah, I mean, any drug at some level.
And we've been having a lot of conversations with our folks in terms of like some of the factors that contributed to the shift in the last 2 years, and because like one of the things we've noticed, because our folks usually talk to us pretty openly about the use, is that a lot of our folks that were primarily using crack or have shifted to meth. And like some of the things they shared is like, A, it's cheaper, it's easier to get, and and like the high is pretty good. But it's also like there was a lot of talk, like at least in downtown Toronto, that like there was this wave where like a lot of dealers were pushing it because I think it was easier to get. Another trend that we also noticed, which was, for me, it was very new, is like we noticed that a lot of our folks who were primarily using fentanyl or like heroin, all of a sudden started going through stretches like of using meth and then going back to fentanyl. And like, I mean, there's something about it that like is working for them.
Like a speedball with cocaine and heroin.
Yeah. So it's like it's at least for me, like in the last couple of years since I've been focusing on this work, like it's a really significant shift. So that's why, and it's also it's causing different effects. Like, correct me if I'm wrong, but it's like a couple of years ago, folks that were primarily using meth, like we weren't seeing some of the behaviors like in our community that we're seeing the last year or two.
I do think it's important to remember, and we would have stressed this last week, but for those that weren't on there, meth is not a new drug. So it may be new to some of us, it may be new to certain regions of the province, but it's been around for a long, long time, and I think we need to remember that. But we definitely there's a lot more interest, and anecdotally, and even some data that would show, yeah, we're definitely seeing more of it.
And I think Toronto's kind of slow on that, catching up to the meth use compared to other cities. Definitely.
In terms of some of those stereotypes, in terms of the types of people that use it, I mean, I always used to think, well, I was first aware of it in the rave scene and the nightclub scene in the late 90s and early 2000s, and people were using it to dance all night long, right? So if you think the other component to this is the setting in which you're using. So if you think about the setting, it was a sort of nightclub, rave setting where you wanted a drug that was a stimulant to keep you awake, and your intent was to use it to keep you dancing. Then I started doing work within the gay men's community in Toronto. So they're still using crystal meth, but the reasons they started using it, or the context in which they were using it, were different. So they weren't using it just in a dance environment, but as a more sexualized environment. And their reasons for using it may have been to do with shame around their sexuality, homophobia, HIV status. So there were different motivations for using it. At that time, there were also other populations in Toronto where you saw young girls that might have been using it as a way of suppressing their appetite. Out west, we saw more sort of long-haul truck drivers using it to give them stay awake and drive their trucks forever. So this concept of drug set and setting helps you think a bit more about who's using what drug and what setting and context, and then thinks about what are you going to experience, and then also what are the risks that come along with that. Okay. So just last week we would have touched briefly on this, but just to remind folks, in terms of the short-term and immediate effects, it's a stimulant, so it gets your heart rate going, body temperature up, appetite, suppressants, you're going to get thirsty, and particularly with higher doses or longer use patterns, you might see anxiety, paranoia, and delusions creeping in. In terms of what an actual overdose looks like, typically people are going to get very red in the face. Have you seen people overdose?
Yes.
Yeah, what's it look like?
So the few experiences that I've had, it was pretty intense. They were sweating, they were super paranoid about anyone coming near them. Some of them had experiences like they felt like they were having a heart attack. It was like we were fortunate that most of those days our doctor was in, so he was able to assist. But it was different. I think we were more used to opiate overdoses. So it was like pretty intense experiencing crystal meth overdose, like because it looks very, very different. Yeah.
Hallucinations.
Yeah.
Auditory. Yeah.
Speak up a bit, Brian. Sorry.
I'm sorry. Yeah, hallucinations a lot. You know, people taking their clothes off because they're so overheated.
Sure.
You know, the heart going so much, and the erratic behavior, I guess, in general.
So if you think of it, it's a stimulant that's going to get people hot, sweaty, the heart might be racing, and then that's where the panicking can come in. And then if they've been up for a long time, also then the hallucinations and the paranoia. So how would you respond to that?
Take them into the quieter environment. If they're in the drop-in, it's pretty, you know, chaotic and hectic. We have an OPS, an overdose prevention site. There's a chill area. They can go chill out. You've got lamps. Lighting's less harsh than the fluorescent lights, and just listen to people. You know, listen to them. Give them a cool cloth to put on their head. A fan, if you have one available, to blow on them, and let them be by themselves.
The key things are around less stimulating environment and keeping them cool. Don't chuck them in a tub of ice, though, because that can overshock them. Okay. So there's a pamphlet there. You can click on the link there on the slide or in the resources section and download a booklet that Katie have printed around how to respond to stimulant overdoses. So these, again, we just said, really is around keeping the person cool, keeping them calm, and reassuring them that things will be okay. And if necessary, you need to call 911 and get them to the hospital. Right. Okay. Don't be giving other drugs just to counteract that. I mean, that's true of any kind of overdose. The more drug, the body's already strained because it's got too much of our drug in the system. So adding more is going to just create more strain in the body. And this is when you really need to be calling 911. So very often when people are experiencing a potential overdose, we can just calm them down, keep them cool. But if they're starting to get these really jerking or rigid limbs, if they've lost consciousness, if they're getting really sweaty and agitated, or their blood pressure is really high, or their heart rate is just pounding, if their breathing becomes a problem, those are all signs where it's getting more serious and they probably need medical attention. So be calling 911 at that point. So if you do end up at the hospital, likely what the doctors would typically do is give people fluids. I mean, the body's going to be dehydrated. They'll just be monitoring a heart rate. And they may be able to give medications to slow the blood pressure and ease anxiety. We recommend that the community members do not do that, but this is under medical supervision now, so doctors know what they're doing there, and they'll be keeping that person cool. And if someone had swallowed it, they may be giving them activated charcoal. So in terms of the other sort of short-term effects and risks, generally it's a drug that keeps people up. They can't sleep. Often you'll see enlarged pupils. That has to do with the sort of flight and flight response. Right? Decreased inhibitions. And some people that get increased libido. Decreased depression or temporarily, People can lose track of time, particularly if you've been up for a long time. And then if you're going on these heavy or extended runs, this is where you'll see the binge and crash cycle come in. So did you, when you were using, how did that play out for you?
I would go on binges and runs for sure. When I first started using it again, it was I was using it to forget about things. I was going through a hard situation, and I wanted to forget all the time. I was just in a really bad place. Things were pronounced to me. I would stay up as long as possible, and the crash was the worst part. No energy, depression, really bad depression, isolation. Yeah.
Right. And you see people coming in, tweaking it, St. Stephen's? Or?
Yeah, honestly, it's like, we try to have a lot of understanding around that, and it's like prior to us opening our OPS, my office.
What's an OPS?
Overdose prevention site, sorry, where we have a chill out space now that people can use, but prior to that, because my office is attached to the drop-in, it became like kind of an unofficial cool-off area, because a lot of times just the presence of others would really exacerbate like things for people. They're having a really tough time mentally and physically, and then like being in a really high stimulus space was making everything much worse. So we found like by kind of giving them a little bit of space, engaging with them on their terms, we were preventing like a lot of things from going sideways.
It will allow them to crash, both of us in our office.
Yeah.
Turn the lights down, give them food, water, you know, and let them talk if they want to talk. If they don't, sit there in silence and let them do their thing. Yeah, important. Or let them have something that they can tinker with. Yeah, good thing. Yeah.
I mean, I know it's unorthodox and that people typically don't use their offices for stuff like that, but I mean, the payoff is really high. It's like usually someone's going to crash for a little bit, they feel safe, they're not edgy during that time, and it's like the way I look at it, it's like it saved my team from having to deal with someone in crisis for an extended period of time. It prevents us from calling the police maybe, so it's like being inconvenienced for like an hour or two in my office seems like a small price to pay.
And I know for myself, from personal experience, being street homeless, having a safe place to just close your eyes is so incredible. It means so much to people. They let you know that as well.
So here's some of the sort of typical things you might see when people are tweaking. Is that term? Is there other terms for it? Tweaking?
Tweaking.
Yeah.
The main one, right? So often some sort of compulsive, chaotic behavior, maybe repeating stuff over and over, endless looping conversations, that kind of stuff.
Hyper-focus.
Yeah. Hyper-focus. So we'll talk a bit about some of that later on, right? Okay. Brian, do you want to just talk a little bit more about some of your experiences around that?
Yeah, I want to preface it with that everyone's experience is different. Mine is not, you know, typical of everyone else's. You know, I was out of Canada for a lot of years. I was forced to move back, and I was homeless when I came back, and it was really tough, and I started using again, and I was using it quite a bit. I've always done drugs in combinations, not just one drug. Mine was with GHB. I was using meth with GHB a lot, I did it mainly for safety as well, because sleeping out there, you don't feel safe. I didn't want to sleep because I didn't feel safe, so I stay up as long as I could until I found a place I could crash out. But I really started experiencing a lot of psychosis. I said being hyper-focused on certain things. I find Toronto to be a bit of a cold city, metaphorically. People weren't the most friendly, and I took it very personally. Very spiritual person, I'm very connected, and I felt very disconnected. And I at one point thought that people were trying to light me on fire, throwing gasoline on me, and I took all my clothes off, and I went to the subway and tried to get on the subway. It didn't fare too well. I was taken to the hospital and left in a hallway all night, like that, which wasn't a very pleasant experience. You know, it's mainly the being hyper-focused thing that I really fixated on. Yeah.
Try and project a bit more.
Yeah, sorry. Mainly the being hyper-focused. I know for me, it was people who listen to me, people would smile at me. That would just make a huge difference to me. You know, I got when people were faking it and when they weren't. Unfortunately, you can't teach compassion. You can't teach that stuff, but just listening to me was a huge deal. You know, although, you know, someone bought me a cup of coffee one day. It was the greatest thing that ever happened in my life, because I was so down on myself. Also, I could pick up fear from people if they were afraid of me, and I'm not really a bad guy. I just, yeah, sometimes people just, I pick it up right away, being hyper-focused. You know, I'd go days without sleeping, without eating, without drinking water. I'm sure that had a lot to do with how I was feeling mentally. And I got out of that, and I still do use meth occasionally, and not feeling, you know, not feeling any of that. And I know it can be used recreationally. I know people who use it who aren't street homeless and going through things, and they're fine, you know. I know the other side quite well as well. Yeah.
I just want to touch, you mentioned the not eating and the dehydration, which I think is a huge piece in terms of how people are coming in, and the extra strains that pushes on the body. And so I think that's something also to be mindful of. Can you offer people just some food and some water when they're coming in? Because that's going to go a long way to helping them feel better.
There's a phenomenon, too, about seeing shadows, and I was doing it all the time. I would see shadows of the corner of my eye. Shadow people, they're called, and I think it's quite common for people to experience that. And I heard it's from not sleeping as well. It's quite common.
Yeah.
Yeah. Scary stuff, man. Scary stuff. Not a good experience.
So there are certain signs that we can start seeing. We talk about subacute and acute psychosis, and we're just going to touch on these briefly here, because you may start seeing things in people that you're working with that are an indication and maybe provide an opportunity for a conversation around where they're at with their use. So if people are reporting that, yes, they're using meth, but they're experiencing sleep disturbances, or you're seeing more mood swings, increased agitation, you see some of the other things listed there, maybe misinterpreting what you're saying, or having erratic behavior, sort of behavior that's out of the normal, that might be a sign that there's something going on, and you might want to have a conversation around, you know, how often are you using? Do you want to maybe take a break, see if this stuff settles down a bit? And it might be a point for an early intervention there. Then if people are experiencing more what we call acute psychosis, this is where people are coming in with real delusions, real hallucinations, uncontrolled behavior. Things seem really illogical or irrational. This is where people probably need to have much more intensive assessment of what's going on, and it may be a point where we might want to consider some sort of more serious intervention. But it's really hard sometimes to know, you know, what is being, particularly with methamphetamine, there's some kind of underlying health issues, or is this drug induced, and at some point does it even matter in terms of how you're dealing with them? So when you see people, is it sometimes they may be on meth, but sometimes it could be mental health stuff, or?
So
yeah.
honestly, personally, in our space, like, it really doesn't matter, and like, we bring this up a lot in terms of discussion with medical professionals, because did a person experience psychosis? Like, their experience is very real, very scary, and it really doesn't matter where it's coming from. We do try to find out more, like when we're working with someone longer term, simply because we're trying to help them, and like if we're trying to get them access to other services. And unfortunately, like, one of the stumbling blocks that we've encountered is either through access to medical records or people sharing with us. It seems that especially, and again, I'm only talking about our folks who are homeless and street involved, because I've noticed things look very, very different for people who are housed and have support systems. So for folks who are homeless, street involved, and do have a history in particular of ADHD, which someone mentioned earlier, or schizophrenia, when they're using crystal meth primarily, the consequences or like effects look very, very different than they do in folks who don't have underlying mental health diagnosis, like particularly in these two areas. And unfortunately, it becomes very, very hard because it seems if they're seeking medical help, even if you call 911, when they're in acute psychosis and trying to get some assistance, the moment the word crystal meth get heard, it's like everything else gets forgotten or erased for some reason, and then like they're not being able to access services around the underlying issues.
So let's think a bit more about this. If people are coming in experiencing some of these behaviors or exhibiting some of these behaviors, how are we as individual workers responding, and what's our sort of overall sort of agency approach and policies? We're going to dig a little deeper and draw heavily on Sandra and Brian's experiences working within the drop-in center there. So, you know, if someone is coming in intoxicated, remember that they're going to be seeing things differently than you are. But we touched on this earlier. The real thing is around maintaining a calm environment to reduce sort of aggravating people. So as Brian said earlier, try and move people into a calmer environment. Make sure that you have an accessible exit. So you got to remember your own safety in mind here. Give the person more physical space than you might normally with someone, so people may need to back up a little bit more. And if you're trying to engage with them and talk with them, it may be that you have to get up and actually move around because they're unlikely to sit still. You see that?
Yeah. It's like our default setting is like I have an emergency cigarette stash. So like the first thing is like you want to go outside for a smoke because when we're out in the open, even in wintertime and cold, it's just so much easier to control the space or like kind of give people that space versus when we're indoors and there are other people around, there are other noises. So whenever possible, when you see that someone is so intensely agitated, it's like we try to take it outside. The other thing is like really following their lead and coming across as being super, super patient. Like one thing that I've observed is like a lot of times because same people over and over again, or like the workers pick up on like, oh no, like this is going to take forever. That impatience comes across, and as Brian mentioned earlier, it's like people are so hypersensitive and really attuned, even more so than when they're in the regular headspace, so they can really, really pick up on that. So coming across as like super calm, like I have all the time in the world to give to you and we'll figure this out together. I find like a lot of times that has a calming effect. And I know like I've noticed some people come from like medical environments or like medical, like healthcare delivery spaces where it's like, yeah, you're like on a timeline, you're trying to help a lot of people, but at the same time, it's like I always try to remind people like, what about safety, right? So it's like if you know if you go this extra mile and put a little bit of patience in it, you're preventing things from going sideways. Like, is it worth it? Like being a little bit calm, like giving the person this space. And like I find another thing is like people get really paranoid when they're in this headspace, and I notice that like addressing them by their name, even if you know them, can sometimes be a trigger. So usually, like if I notice that that's where things are going, I have a tendency to ask people like, what do you want me to call you? And I've been given like some pretty creative answers. Like one person told me Godzilla. So it's like the rest of the and like even though I knew his first name, the rest of the interaction, I addressed him as Godzilla, like everything was on his terms. So just kind of remembering like this paranoia can be triggered like by ordinary things that we don't really consider can be super helpful.
Also, getting to know the client, and if you know there's something that it means a lot, has a lot of meaning to them or special to them, you know, talking about trying to redirect the conversation to that helps a lot. I also want to say, be safe, but don't be afraid because it's easy to pick that up. I know I picked it up easily, and it changes the whole mindset of the person. People can tell that. We'll use that. Mostly, yeah. Change their headspace.
Yeah.
These are some other practical things you guys have tried out there.
Yeah, as Brian said, like a lot of times people are overheating. They've forgotten like just basics like consuming water. So that's one of the first things we offer and we keep offering. We do have fidget baskets at work because like a lot of times people are really, really restless and they're looking for something to do. Or like with our folks, because there's street involved, like they'll get like really zero in on repacking their belongings, and it can be annoying and disruptive, but just let them, because like a lot of times keeping their hands busy is kind of calming down their brain. And again, overheating, it's like, you know, when they start taking their clothes off, the best you can do is like sometimes negotiate, like let's just keep our underwear on. It's like, you know, we'll take that as a start, because because like they genuinely feel like they're on fire, right?
Yeah, and trying to avoid having people who have conflict with each other be near each other, mitigating it before it happens.
Yeah.
So these are all things that you said, a lot of just listening.
Yeah.
Right?
Definitely.
Honestly, it's a lot of patience, and of course, like with any other de-escalation, it's so much easier if you have rapport with the person. So it's like what we're seeing in our services, that a lot of times we're dealing with the same people over and over and over again. So we really try to focus on building relationships with those folks when they're not in crisis. But I find the more we do this, it's like it's default setting, even if I've never seen someone before in my life. Like, as you can see, I can talk a lot. I try not to do that when people are in this space. Like, I really focus on them. It's like, it's really about them talking, even if what they're saying doesn't make sense. I just go along with it as if we're having like a regular conversation. I'm not arguing with what they're saying. Like whatever they're paranoid, whoever they're angry about, like we just let them vent. You just kind of roll with it.
Not dismissing it is huge.
Yes, exactly. Like really, really like letting it be about them can shift things so drastically, and a lot of times that's going to end up helping bring things down. I don't know. Do you have anything to add? Did I forget anything?
Yeah. I'm not feeding into it, but not dismissing it.
Yeah.
And here it says, using just short sentences, and then also tolerating having to repeat the same thing over, or hearing the same thing over and over again, because people's their minds may be in a loop, or they may not be remembering stuff or processing things. You may have to keep coming back to the same thing over and over.
And it can sound pretty out of this world as well.
Yeah.
The other thing was, if you are going to say, come back next week and let's set up an appointment, make sure you write that down, because people's ability to remember things is maybe, they're not processing, embedding those memories. Write stuff down for people too, if you're asking them to follow up later on. There are also things that you don't want to be doing. So, Brian said, don't be dismissing stuff. But you don't want to get into arguing with them, or you said some of the stuff you hear is pretty out there.
Yeah, for sure.
Yeah.
It's been pretty interesting. I'm sure I've said it myself. Yeah.
If you start arguing with them and challenging, that can just escalate the situation. So it's sometimes just best just to go with the story, even if we know it's a bit outrageous.
About building trust, right?
Yeah.
About building trust.
Don't get people locked into a physical space, because then they can feel threatened, right? And don't use physical restraints. I think that's a given, but that we have heard of people saying, we had to tie this person down. And then eye contact is a big thing. So I guess it depends on the person as to how you...
I really like, this is the big one where I really go by my previous relationship with the person. Because like there's certain folks that I work with, there's a couple of them in particular in which like getting them to look me in the eye actually brings everything down. It tends to ground them because they know me. And like one of the rules I have is like, doesn't matter what, like I never lie to folks. And that's a chip that I cash in when they're really in crisis. So it's like one person this happened on Friday, like he was really, really in crisis, and it was like we couldn't get him to connect. There were times like at moments like I had to repeat my name. It looked like he didn't even remember who I was. And I kept asking him, like, can you just look me in the eye? And he did. And it was like, it's like curtain went up. And it was like we could actually communicate. But really, like, I only recommend that if you have a rapport with the person and you kind of know that this has worked in the past and there's already a pre-existing relationship based on trust. Otherwise, as I said, like, kind of just be aware of your own feelings as well, because people have a tendency to shout. They can look intense. We haven't really experienced anything horrible, like, in terms of effect on us. People don't really touch us. They don't do anything to us, but it can look really scary looking from aside. And I find it's just like the people just get louder. They get more intense, but they don't really engage physically. So just kind of trusting your gut in terms of that as well, I think, can calm things down quite a bit.
So just again around not arguing, no is not a good word to be using. Be clear about what you can provide. Don't take things personally.
You can't do that.
Yep. Yeah, we get, like, there's a tendency to get called every name in the book, like, especially if a person wants something that you know you can't provide. It's like the way I avoid no is, like, I try to kind of dance around to see what we can provide. Like, is there another way to kind of approach that need? So instead of saying, like, sorry, I can't do that, and it's like, I try to kind of ask short follow-up questions to kind of try to come at it at a different way, because obviously it's like we all have limitations in terms of services that we can provide, or what we, like, there's sometimes when people are asking, it's like, it's just really impossible. But it's like, really, I know that's a hard one to remember. It's like not saying, it's like, no, that's not happening, like, it's not going to happen. Right? Yeah, it's like offering something. It's like, when we figure this out together, I'm really trying to help you here. Can you help me help you? Like, can go a long way.
And don't be asking lots of questions. Keep it simple.
Yeah,
try
really,
to keep the
really
interactions
simple.
as simple as you can.
Yeah.
Okay. So if people have become more aggressive then, so there's some tips here in terms of just, again, trying to keep your emotions in check, keeping calm. But there's even things like body posture. So as I said earlier, give the person more space. There's even tips, I think this is from the Australian resource, in terms of just keeping your hands, palms facing forward. These are all things that people see, feel, and perceive as less threatening. Yeah. And let people get their aggression out, but be flexible with them, obviously within reason. And then there are structural things within the work environment in terms of limiting potential hazards, working in teams so you can hand off to each other if necessary. Do you have any kind of alarm system or alerts in your environment?
Yeah, we use walkie-talkies, and like we use like the power of tapping out whenever necessary, because sometimes it's like, it's also remembering that it's really not about you. So it's like you can be the most amazing at de-escalating people, but there's just something about you, about the way you look, about the way you sound, that's triggering the person at that time. And like that's one of the reasons we always work in pairs. And it's like sometimes it's also like kind of giving person a breather from like repetitive interaction with one person. So, or like if you notice that they're responding better to your coworker, like I tap out immediately, because like whatever is going to get us to a peaceful resolution of the situation. And then another thing to remember is like I find a lot of times we focus on the person in crisis, and like when they are in crisis, they tend to attract a lot of attention. So crowd management is like a big one, because people approaching, even people shouting things at them can actually make things worse. So like we do tend to focus a lot of the energy on our team and kind of like ensuring that nobody's close by, that there's like a lot of space, and like trying to distract people with other things, so like that there's not a lot of audience, because I think that tends to make things worse, like in general, right?
Here are some other tips, and again, I think these come from that Australian resource. So this is that purple document or in the treatment approaches for users of methamphetamine. I think in the resources box there, I encourage you to download that. There are just some other things here in terms of, again, around body language or positioning yourself, but also not completely ignoring when people are escalating. So are there particular signs that you see in terms of when people may be escalating and what's triggering that?
Chairs.
Yeah, in our space, it's usually chairs flying, where it's like at time to take a step back. Like if stuff's being thrown, or like if they start hitting a wall or hitting a chair, like I'll typically like take a step back. But we've never, like in all the times that I've been doing this, it's like we've had like some pretty big crises. We've never had like anyone hurt any of the staff while we were dealing with them and crisis.
Today too is if they're yelling, it's a good thing, because if they're not, usually they're going to hit. They're going to do it right away. They're not yelling into it.
These were just some signs that people may become more aggressive or violent if they're already coming in very intoxicated, or they obviously have a weapon with them. If they're particularly restless or agitated. Stimulant drugs often cause a lot of clenching of the jaw, fists, so people might be getting like that. The one I really wanted to draw attention to, though, was actually the worker's reaction, or at the bottom here. I think this is the one that we often forget. We often think about the client piece, but how are we reacting to the client, and how are they perceiving us and our reaction? And you said you could pick up on fear and anxiety. It's even more intense maybe when you're under the influence?
I think so, yeah.
And I think like in spaces outside of ours, like I've seen like the default being calling the security right away, and it's like without any attempt to engage, and that can really, like you would think that's helping the security, and again, like safety, and I know that in some places that's the protocol, but I find a lot of times the uniform of any type like actually makes things way, way worse.
So we've been talking a little bit more about as individual worker, as a team, how you might respond, but as an agency, we're just curious here. So you could just answer this poll here for folks on the webinar. Does your agency use service restrictions or ban people?
Mm-hmm.
So we got a sort of like a 50-50 split, maybe, roughly. I'm going to pass it back over to Sandy here. Maybe do you want to just talk a little bit about how you guys, or Brian too, jump in, how that's worked, and maybe just define that for two that aren't sure about it.
So I know like a lot of agencies that provide like social services or like healthcare services, do you use service restrictions like when people exhibit challenging behaviors or when they're perceived as a safety threat? And I find a lot of times it's like, okay, this is the amount of time you're going to be away, and this is how you're expected to act, but like there's really a conversation about why things happen in the first place, and we really try to focus on this last thing, and I think that's where like a lot of realization happened, that majority of folks that we were having frequent ongoing issues with were using crystal meth. Like we realized that they were the ones who are constantly ending up on service restriction lists, and not just in our spaces, but like pretty much in all the other agencies around us.
Where they couldn't access services.
They couldn't access services, like they would get banned from spaces like OW, ODSP offices, even central intake, respite centers in wintertime. So like there was a really high correlation between using crystal meth, having mental health challenges, being street involved, and having no access services. So we really try to be cognizant of this fact and like really involve people in the conversation around how to address this long term.
And if they're able to, we have restorative justice practice.
So they're actively involved in the process around the service restriction. So rather than us telling them you can't act this way, like if you want to come back, they're actually part of creating a plan in terms of like, we'll have a detailed conversation and we'll write it down. Like when they're in a better headspace, they will tell us what helps them or what they think helps them in those situations, and how much of a role we can play in terms of preventing things from escalating to a point where they're getting a restriction. Also, I believe that realization that a lot of it revolves around crystal meth has shifted a lot of our focus on prevention. So a lot of the symptoms that we were talking about before, we're really trying to zero in on like what phase someone's in the moment they come in and not wait till they come to the point of a crisis. So, you know, really increasing the frequency of positive interactions, really to kind of meet them of like, what's happening, how can I make this better, what can we get for you, before they get to that space where they're like exhausted, sleep deprived, like really frustrated, and then one person looks at them the wrong way and all of a sudden the entire day is not happening in a smooth manner anymore. I don't know, I just find like service restrictions are a very complicated thing. I also feel that a lot of times when we're advocating on behalf of people in other agencies, even like let's say when their caseworkers were there and observed certain things, there's very rarely like reflection time because for instance, like when we have big incidents like this, we will spend a lot of time dissecting our response and like really reflecting of like, did we contribute in any way to how the event unfolded? So and like, how can we do better next time? So I find like in the last year and a half, like year and a half, since we've been really focusing on this and working from a restorative justice point of view, the number of 911 calls we've had to make has kind of been cut by half, which I think takes a lot of pressure off of the community, off of emergency resources, but also like it helps the team that's delivering the services. Oh, sorry. Thank you.
Sandra was just going to spend a little more time speaking about the population, I think, in some of the intersections that they're working with Stevens there.
So I keep repeating this because like I've been exposed quite a bit to folks who use crystal meth recreationally or houses, I said, who have active support, and I find like the challenges are very, very different than in terms of folks who are experiencing homelessness. And I mean, really, like, you don't need any like high degree to kind of figure out like if you're homeless to begin with, like you're already under a lot of stress. As Brian mentioned, it's like, you know, people are just kind of trying to figure out, you know, where am I going to sleep? How do I prevent people from stealing my stuff? But then, you know, you introduce the element of crystal meth and things are automatically more complicated. So some of the things that we notice, like in terms of our community, it's like they have a tendency to accumulate a lot of things. And like they'll be coming in with like bags and bags and bags, or they'll be carrying like the most random stuff from the community. Like we've had armchairs, you know, like computers, stuff appear on our doorstep, which like obviously we can't really accommodate all the time. And we will talk to people like within reason, but if someone's in crisis and it's like setting up camp and kind of repacking their things is helping them out, as exasperating as that may seem, we really try to work with them around that, and we're really recognizing that that's something that's like really tightly connected to their crystal meth use, and like honestly they can't help themselves at that moment. It's like repeating that path is what's kind of keeping them calm. So again, like our program closes at some point in the day, so it's like we've come to recognize folks who tend to engage in these behaviors. So we'll kind of start the packing up process with them earlier than with other folks, you know, kind of to prevent frustrations around that. I've mentioned sleeping. It's like, as I said, as unconventional as that is, it's like a lot of times, like having someone hang out in my office while I'm still doing my work, it kind of makes them feel safe. It helps the connection. It helps them reset. It prevents crisis from happening. Another thing is, like, I know, like, obviously a lot of spaces will restrict people because of theft. And like another thing that we did notice, like in our entire kind of little sub-community with meth, it's like if you tell people that they stole something from someone, they will get really mad and really offended. It's like there's really something tightly connected to meth use where it's like people's perception of what's yours and what's mine really shifts. So like they'll see a jacket, they'll take it, but it's like they just took it to wear it for a little while. They didn't really steal it. So kind of being aware of these perceptions really helps conversations, I find, around service restrictions. And the big one was bicycles. And like for us, it was like it did matter because like our program is in the heart of Kensington Market downtown. It's like a pedestrian family area. It becomes really busy, and we were having like folks set up camp with their bikes. They'll spend hours taking their bikes apart, working on them, stealing them from each other. So kind of being aware of that, like we focus a lot of our energy and kind of like we have staff people who are outside and they'll keep an eye on things to prevent bikes being taken. As I said, like prevention does go a long way, like being aware of things like this. It's like in terms of service delivery, it's like I know, like shockingly enough, we even had one of the court workers. So it's like a lot of our folks have involvement with criminal justice system. They don't have locks. They show up with a bike. So it's like a few weeks ago, we actually had a bail worker at one of the courthouses come outside with her laptop to babysit clients' bike so he could go inside with his worker and check in and show up to court, which I found was like completely amazing because he showed up there, but he was like, I'm not going inside because like I don't have a lock and I'm not leaving my bike outside. So, I mean, going out of your way, being creative in that way, like you're helping a person, but really like I find like crystal meth really requires thinking outside the box. And then I think I already talked about schizophrenia, ADHD, and pre-existing mental health diagnosis. And again, I don't think this is new information for a lot of folks, but I really find there's something different. And again, like I looked, if anyone has access to studies, please feel free to share them with me. But I find there's not much interest in research in terms of population that's treatment-involved or homeless. There is something about pre-existing schizophrenia condition or ADHD and crystal meth that really makes people experience psychosis in a worse way than the rest of our folks. And unfortunately, as I said, like despite all of these supposed programs for concurrent disorders, good luck accessing help for either or, because the way it works, it's like basically, it's like, yeah, we'll help you with your mental health stuff if you're sober. But a lot of times, one of the primary reasons, I mean, as we know, people are using is self-medicating. Do you have any?
You hit it all.
Yeah, I'm like,
Do you ever struggle accessing services because people just are like, oh, you need to do the drug use first? Or...
Oh, yeah. Even like I couldn't see me until I was sober. Yeah. In the hospitals were the workplaces, and I've experienced that with clients myself. The judgment as soon as they know that the person's a drug user. Pretty shameful, actually. it's so difficult to access services.
So are you able to, as clients, as workers, go with clients to hospitals to advocate on their behalf?
I do, definitely.
Yeah.
I can do that, yeah.
I mean, unfortunately, and I'm really sorry to say this, it's like even as workers, we don't tend to be heard frequently when with a client who uses crystal meth. And I mean, a lot of time, like I know experiences where like, well, I don't know, client had his feet up on a chair in a waiting room in a hospital, and it's like even though the worker's there, it's like trying to communicate to the staff that like the person's not doing well at the moment. This kind of like our pathological needs for like rule enforcement kind of overrides a lot of times all the trainings we've been given. And I mean, this happens in social services as well. I've watched this like with staff with different agencies. So it's like we'll have repeatedly trainings around crystal meth, and we'll all nod along as we're talking about this in theory, but we come to practice and it's like all of it goes out the windows, and like this battle of the wills happens. Is like, you know, I'm going to make you do it my way, or kind of, I don't know how to, it's assumptions about what the person's capacity is, or like assumptions about what is going on with them at the moment. And I find like this is not coming from a place of judgment, like just so we're clear, we're all overworked. I don't know anyone in this line of work who's like underworked. We're dealing with a lot of competing priorities, but I find it's like sometimes we forget that we're there for the community we serve, and it's like we're the ones with the power to kind of control the situation. And like when we're saying meeting people where they're at, we're the ones who are supposed to be doing the meeting.
Brian, some people just couldn't quite hear. I'd asked if you are able to go with clients to a hospital, because you were talking about the...
Oh, definitely, yeah, I can and I do. And like Sandra said, it doesn't always make a difference because,
right.
Yeah, people are still, once they find out people are using crystal, they just dismiss them.
So some of the words I keep using, it's like what I found really worked in our program is really creativity. It's like this is one of the things, like crystal meth, like I know all of substances, like all agitations, all crises require us to think on our feet. I find crystal meth more than anything else is really requires us to be flexible, to kind of think in the moment and to be creative. And again, I do recognize I worked at a hospital. It's like when you work in a setting that's very policy procedure driven, there's only so much you can do, but at the same time, especially for folks working on frontline, it's like we do have a voice. If we're seeing that something's a barrier for folks, we do have an option to bring it up in our meetings, to reassess policy, to reassess procedure, especially if it increases safety both for the folks that we're serving and for us. Like at the end of the day, we all want our day to go smoother. We all want to go home safe. And as I said, like because we are seeing more quote unquote problematic or like aggressive behavior in folks, I find we need to go that extra mile to make sure it doesn't happen that way. And I mentioned most of these, but I think both Nick and Brian, it's like really focused on listening. I know that time is like such a precious commodity, but if you can spare some and listen to the person, it's like it's really shocking how far you can get with a person with a combo of empathy and actually giving the person space just to talk.
Being dismissive really adds to the shame, and I think shame is the biggest killer. It really is. It adds to everything, and it can be terrible. So listening is an awesome thing.
Yeah. So we've, like in our particular program, we've been really trying to get creative in terms of like not just dealing with crisis, but how we engage with our community that uses primarily crystal meth. So we have DM groups, so we actually bring folks together and they're the ones making harm reduction kits. They also have kind of a safe space to just kind of chat. It's kind of an informal support group. We also started a bike workshop, so we have a designated time, like after our program closes, in partnership with the city and an NGO that does bike work. So we have a mechanic that comes in. And I mean, honestly, it's beautiful seeing our folks engage in something positive and have space to do something that they're passionate about without being told, no, you can't, you know, don't do this, don't do that. We also, so we work in partnership with inner city health team from St. Michael's Hospital, and we're so fortunate that our GP is like really cutting edge and listens and connects with our folks and is really opening to exploring alternative routes. So one of the things that we have been trying for about over a year now, only with specific folks, he's been prescribing dextroamphetamine, and that brings me back to someone who was earlier mentioning ADHD and folks who have history of HDD, because that's another thing. Like we've noticed that a lot of our folks who are using crystal meth now were on prescription ADHD medication in the past, and that kind of led them the route of using crystal meth. Again, not like a default prescription for everyone using crystal meth. It's a really complicated process, but like we've kind of recognized a subgroup of folks who are suitable candidates for this. And from a harm reduction point of view, I don't know if you would agree, but because like you work with some of the folks, we've seen quite a bit of difference in terms of folks reducing their use and by default having more opportunities to deal with more things versus just kind of hitting their head against the barriers that are coming as a result of their crystal meth.
Just have one client in particular who's really responding well to it and is engaging a lot more and is being involved in peer work and so forth, and it's been pretty incredible, the difference. And so, as you said, the doctor is amazing. He works really well with people. So
yeah, look, it involves a lot of follow-up, checking in with folks, monitoring them a lot, but as I said, we're exploring this as an alternative, and so far it's been really positive. Again, we've also tried to do modified access instead of service restrictions. So we'll try to accommodate, like let's say we'll try not to cut off the person from access to health services. We'll arrange a time for them to be able to see the doctor, even if they're not in our drop-in. Or yeah, exactly. Or like if they have a case manager, worker they connect with, we'll arrange access to shower off hours when they're less likely to be triggered by others.
The overdose prevention site, we won't deny someone access to that.
Exactly. Yeah. And like little things, like do pay attention and do share information with each other. We found with a lot of folks that we were having a lot of issues with. So it's like they'd be connecting with certain workers, but not necessarily with everyone. And it's like going out of your way to make sure they know workers' name. It's like just as it works for us, right? Like in a sea of folks that we're working with, if you know someone, if you know their name, if you know their story, you're going to work with them very differently than with someone you don't know, making it personal for them. So making sure you're a human being with a name to them goes a long way in terms of how they're going to respond to you in crisis.
Okay, so we just wanted to, let's shift it up a little bit just to finish off here, and then we're going to open it up for questions. So we wanted to spend a bit of time just talking briefly around if we are engaging with people and now they're looking to change their use. So what kind of supports and resources are there out there? I'm going to preface this by saying I'm in no way an addictions treatment or a substance use treatment expert. And there's definitely less we know around how we can support people around, or from a more medical standpoint, crystal meth compared to opioids. But there is some good stuff out there. Also, I just wanted to bring this up. Remember at the beginning of the webinar, we had these the faces of meth, where the media love to portray people and use these scary pictures. Well, some of the people that have been using those ads, I forget where this came from. You can click on the source there. It will take you to the article about this. But they found, this journalist went after and found these people later on and found that actually people do get better. Very often people can get better on their own and don't need support. But then some people do actually need support. And I think the important thing here is just that people do get better. There is hope out there, but it's a process. So there's initially in the withdrawal symptoms that people may experience. It maybe not. Is it the same as? It's not the same as opioids in terms of how severely sick people get. Would you say?
Oh no,
Yeah.
it's nothing compared to that. Yeah. Yeah. But the crash is pretty intense. And,
Crash is intense,
Crash
right?
is intense. The depression, lack of dopamine, and you sleep a lot. You sleep a lot. You don't want to get out of bed.
People will isolate,
Yeah,
so it's important to maybe check in on folks, how they're doing. But this is a period of time where it can take several days, but you really just need to sleep and eat. You probably haven't done that in days. And there may be some pharmacological support in terms of managing some of those symptoms. And then there's also sort of biopsychosocial supports that we can be offering people. People need to be prepared for that crash, so let them know that you're going to be experiencing this, that you will be feeling like shit mentally and physically. Don't beat yourself up over that, though, and take it slowly, a day at a time. If you have these persistent symptoms of depression or self-harm, that's a caution there, or maybe there's some alternative things we could be offering people, and developing plans around them. So have you, I don't know how into this you get with folks, developing plans?
I always do that. They develop the plan. We sit together and they look at, how they want it to look, and I give them, suggestions, and yeah.
What are some of the practical things that people do then to manage that crash period?
Just letting they stay home and rest.
Stay home and rest.
Check on them, make sure they're okay. Like you said, make sure they eat, drink water. And talk about any depression or something that's going on, such as that psychological. So they're not keeping it to themselves and hurting themselves.
And reminding people too that you have ramped your brain up at a neurochemical level, and that can induce a sort of chemically induced depression, but that will resolve or should resolve over time. And this helps explain some of that. So last week we looked very briefly at some of the neurochemistry behind methamphetamine. But basically our bodies are always trying to maintain some kind of homeostasis. And if you're ramping stuff up all the time, your brain's going to compensate in a particular way, and then you take that drug away. And it can be very hard in that early recovery period to create feelings of just normal feelings, or those pleasure and reward of good feelings. So it's important to remind people that because your brain has been chemically altered, it doesn't mean that it's always going to be like that. Our brains are much more plastic than we realize, and they can recover, but it can take quite a while to do that, up to months sometimes. So this is a resource here that originally this came out of King County in Seattle. It was developed by people who use methamphetamine for people who are struggling with methamphetamine. The AIDS Committee of Toronto has redesigned it and developed it. It was originally intended for gay men, but it's useful, and there's applicable stuff in here. You can click that link here, or it's available in the resources box. What I really like about this resource is that it goes through very specific stages that people are going to experience. It talks about the fears that people may have going into this, but what is the reality check, and what are the positives that people are going to be experiencing, and it really breaks it down into specific time frame. We'll find there are distinct phases people go through, and usually it's within the first few hours, and the first few weeks, and then the first few months. And this talks about the pluses and negatives in each of those, but it's very practical stuff, and I know many people that have found this to be a useful resource in terms of what that trajectory you're going to be going through, and what you can expect, and what kind of support you might need during each of those time periods, but also what are the challenges, because as time goes, new challenges are going to come up, right? I know much of the work I had done in the past with gay men, one of the big issues was that meth and sex had become intertwined. And in order to stop using meth, they had to stop having sex. And that was very challenging for folks. But this is some really good practical stuff. So I encourage you to download that resource. I think it's called Staying Off Crystal or Stimulants for a Day or Longer. There isn't, in terms of actual sort of treatments, this comes from a psychiatrist here in Toronto, Tim Dumont, and he's looked through the literature, and there are various different models out there. Nothing really concrete yet, but there are different, again, I think it's important that we remember there isn't one solution to all of this. Everyone's going to be different, and we're going to have different approaches. So some people are going to work well in an abstinence-based model. Others are going to look more in terms of reducing use and managing use. We don't have the same kind of pharmacological alternatives that we do with opioids, but I'll talk about a couple in a second. It's more to do with managing symptoms. So it may be that you require some antipsychotic medications or benzodiazepines that help with your anxiety. Right? A lot of group therapy. So I know in Toronto and in other parts of the province, you're seeing different types of groups and group support coming up. Did you ever actually look for treatment, or did you just manage to sort of do things on your own?
No, I have gone to treatment before.
And was there anything that for you found useful or challenging, or have you heard of other folks?
Just being out of the environment I'm typically in. It's a good break to get away. But reality happens when you're out of it again.
Yeah.
You know, listening to people and letting them express what's going on, trying to stay busy, and positive, you know, whatever you feel is positive for you. Yeah. I don't think abstinence is always the best solution. It depends on the person. What the person believes is going to work for them. Slowing down your use is good, and, you know, yeah, whatever's going to help. Everyone gets to decide what that is.
Yeah.
It's individual, definitely.
So these are some things that have been tried out there in terms of trying to reduce use. I'm not going to go through each of these, but Tim Dumont pulled this out of the literature. So there are people trying different drugs out there and just helping with maybe reducing your use of cravings. But again, there isn't a sort of magic bullet, and there's no equivalent that we find with the opioid, such as Suboxone or methadone. But you guys have talked about dextroamphetamine. Yeah. As a potential thing. In terms of that connection to sex, I mean, this is true for many gay men. It may be true for many straight folks too, or women that can be tie-in with sex. So this is a guy named David Stewart from the UK, and he has a whole YouTube channel, done some really amazing work. You can click there to look at that, but he has some sort of tips in terms of trying to untie that connection there, or talk to people about that connection to sex. So if that's a conversation you're having with clients, I'd encourage you to look up David Stewart stuff. And this is a resource, again, this is Gay Men's Focus. This was a website back in 2005. It has recently been updated. It's called Hi, My Name is Tina. Tina is a name for crystal meth, very common within the gay community. While this targets gay men, there's useful information, just practical information about crystal meth, and particularly around some harm reduction tips on there. So again, that may be a good starting point if you want to just learn a little more in terms of harm reduction tips. And then if you're working with youth, the TRIP project in Toronto, they have a website which is accessible to anyone around the province, obviously, and they have sections on methamphetamine there, and have been talking about meth for as long as TRIP's been around, 20 plus years. It's very youth-focused and uses language and practical information in a non-judgmental way. So I encourage people to look at that, particularly if you're working with youth. These are the Australian resources I mentioned earlier. So we borrowed a lot of stuff from this purple document here, Treatment Approaches for Methamphetamine. It's a big book. It's back from 2008, but there's some really, really good stuff in there. So that's available in the resources section here. And then recently I've discovered this website called Cracks in the Ice. I still have not, there's so much information on there, I still haven't even gone through it, but it's a very comprehensive website, far more in-depth than anything we've been able to do today. Includes all sorts of resources, toolkits, and webinars, recordings that you can watch. So if you really want to explore this further, there's limited resources right now in Ontario, but Australia's ahead of the game. They've been dealing with methamphetamine for a lot longer, in part because it's a lot harder to ship cocaine down to Australia and a lot cheaper and easier for them to manufacture methamphetamine. So they've been dealing with meth for a long time there and have some really good resources there. And then if you're a really geeky person and want to read the latest literature review, this is 4 years old now, but this was the most comprehensive thing I found recently, looking at the epidemiology, the pharmacology, and some of the treatment stuff. There's a link there if you want to go and explore that in more detail. We're going to open it up to questions. I'll come back to some of the questions there, but before I do that, just want to quickly mention this is our contact information here. Feel free to follow up with us. This is going to be our new website, the Ontario Harm Reduction Network, and Brian and Sandra's emails are there. And we also just ask that you fill in an evaluation form. So we have another half hour. We'll see how much time we take. But let's go back through. You can click that evaluation, fill that in right now. We really do appreciate your feedback. But let's see what kind of questions we had here. So these are some comments that Kim had noticed from the chat. And feel free, if you're still listening in, to add some comments or questions in the discussion. It's a chance to talk. Brian specifically, or maybe his, some of his experiences, or Sandra around the organizing experiences. Let's see what we got to start us off with. So Amanda was talking about a lot of their clients stated they use it to feel normal, and often these people had a history of ADHD and benefited from ADHD drugs. Yeah, this was something in part one we talked about this last week. There's definitely some kind of connection going on here. And if you look at the drugs that we prescribe people for ADHD, drugs like Ritalin or Adderall, they're pharmacologically very similar to amphetamine or methamphetamine. And then you just have to look at the kind of behaviors people are engaging in when they're tweaking, very focused on something. So there's definitely some kind of correlation there. We think probably a lot of undiagnosed ADHD in this population. Beth was making a comment around banning the behavior, not the person. Okay. Yeah, some places are using these situation tables. I don't know a ton about those. Do you know much about these?
So we participate at a focus table that's facilitated by Toronto Police Services and United Way. We sit at Toronto West One. We've also, I'm not going to name any names, but certain people sitting at the table have been bringing up the fact that we're dealing more and more with folks who are using crystal meth or street involved. So we have started tracking that as a separate criteria to just kind of get a better sense of the numbers Toronto-wide. And like I believe we looked at cases in the past 2 years, and there is a significant shift this year, like a really drastic increase in numbers in terms of number of the cases, these kind of like high-risk folks who have frequent interactions with criminal justice system, with the police, and a lot of the agencies or service providers are not really sure how to work with them. So I don't know what the answer is. I believe someone somewhere down the line might come up with a crisis center that's actually going to provide adequate services and provide help to these folks when they need it, how they need it, both in terms of mental health and like physical things around their substance use, but that seems a little while away.
Brian, I'm wondering if you can answer this question. So there was do people remember the situations where they have had a tweaking episode and became very agitated at an agency?
I'm going to speak for myself.
Yeah.
It was funny, I was having this conversation with a coworker yesterday. I remember everything vividly, so vividly, and like the most serious psychosis, and I remember it all clearly. I can't speak for everyone else. I ask clients sometimes, and they don't, really give me an answer. I haven't really got an answer that, I don't know. I think a lot of times I could be, judgmental here, but it's because they don't want to admit, what's going on. I know for me that was very vivid and it was going on. I was never aggressive. I was just always very afraid, very scared. This type of person I was. I was afraid of everything, and I remember that fear very well. Yeah.
I know our program, the Ontario Harm Reduction Network, is based out of Five House, which is a housing organization for people that are HIV positive, and we have a number of people that come in and are often working with our workers, and they may be tweaking. And then some of them are very embarrassed by what they've done, and that takes a lot of guts to kind of come back in and talk about that and how you're feeling, and maybe you don't actually want to come back in because you're embarrassed about it. So it's around trying to be non-judgmental about what happened the past time, so that people don't feel afraid to come back and engage with you. Right? There was a question here around, can you review the medication side? So I'll just go back to the slide. I'm not sure specifically which one this person's looking for. Maybe this next one.
Yeah.
Natalie, you there? I don't know if that's the slide that you were looking for. Remember, we will send these along after the fact, so you can review them again. But those are some various different things people have been trying. There you go. Any other sort of questions or comments from the folks on the webinar for us? Kim, has anyone sent you a private message? No? Okay. Maybe we're going to be finishing early. I don't know if any of you, Brian or Sandra, have any sort of final sort of comments. Hopefully this has been helpful to folks. This has been a starting point for us. We're always looking to change and adapt our work. So as I said, please let us know what's useful, what didn't work, what worked for us, for you, what's missing. We've got a couple of people typing here, so let's see. Anything else you want to, we've not touched on, or?
I honestly can't think of anything. I just wanted to let people know if they have any questions, so feel free to email either one of us. We've had that after the previous 2 webinars. If you have questions specific to your agencies, if you want something clarified, we'd be more than happy to respond. And again, we don't have all the answers. We don't pretend to have all the answers. It's just like we've really been trying to focus the light on challenges that our community is facing, like around their crystal meth use. So like even having this conversation and people being open to kind of discussing these things in the context of like services they provide in their agency, I think in the long run will help the folks we're working with.
And I think the importance of having a team that is all on board, which is pretty high ideal. But if I know in my experience where I am, St. Stephen's House, we have a really good team that's cohesive and we work together, and it helps so much. It helps so much.
Lisa, yeah, we will be making the slides available for download, or they will be sent to you as part of a follow-up email to this, including the recordings of the webinars, so that you can share this webinar with anyone that wasn't able to make it today. Monique, you have a question around what more can you tell us about overdose prevention sites? Maybe you could let us know. I mean, that's a very large, broad topic, so I'm not sure what specifically you would like to know around those. I don't know where to start with that one. So maybe you can just tell us a little bit more about what you're looking for there. In terms of, my perspective on those, the overdose risk from methamphetamine use in terms of people ending up dead is not the same as if they're using fentanyl. Right? Doesn't mean that people can't get too intoxicated too high. It doesn't mean that we don't want to create safe spaces for people using all kinds of drugs. But the overdose prevention sites are sort of addressing a more immediate concern around particularly the opioid drugs, I think. But I can tell you my experiences, I was very involved with a Moss Park overdose prevention site when we first got it going, and there were still a significant number of people coming in and using methamphetamine in there, along with other drugs. It's not just about overdose prevention, it's also just about creating a safe space in which people can use without fear of arrest. They can take that time to prepare their drugs, and it's really about building relationships with people. That's what these are about.
Connecting to other services, yes. it's also.
Here's a question. Any advice on how to help people manage picking? Because I don't think that's something we really talked a lot about.
No, we didn't.
Even in last week. So this is maybe you can define what picking is, and then any tips around that.
I've tried. It's not happening. I don't know. I don't have tips for it. Distraction probably the best thing. If you can distract someone from doing it. People believe there's things under their skin. There's a term for it. I can't think of what it is, Nick. Do you know what that term is?
The technical term is formication.
Yeah,
you feel like that
formication.
things under your skin. It's
Scrolling,
very
yeah.
common with methamphetamine particularly. And people will end up with all sorts of scars. Just trying to distract people, I think, is all we can do. And it's not clear what's causing that. Is it some physiological reaction to the drugs? Is it the drugs actually, or toxicities within the drugs coming out? I don't think we see people on ADHD medications picking away like that. So is it to do with the fact that you've just been up forever? Is it toxins within the drugs? So I'm not sure. Okay. Anything else for us here?
I think Monique clarified. I think she just wanted the clarification between safe injection sites and overdose prevention sites.
You can think
Common
of them.
question.
You can think of them as the same. There's a slight technical difference in terms of the legal framework and the funding and who approves them, and one's a little more low threshold, low barrier than the other, but they're basically the same thing. They're basically a sanctioned space where people can come in and use drugs under some kind of supervision. And we can respond immediately to overdose and hook people up with resources. They're basically the same kind of thing. Yeah. Okay, well, I just want to thank Brian and Sandra for all your help on this. So thank you for that. Encourage everyone, again, please fill in our evaluation form here. It really will help the Ontario Harm Reduction Network in terms of thinking what our next steps are, what was useful, what didn't work, what did. What else you would like to see from us as we move forward. A lot of these webinars and online learning is new to us. We're still figuring this out and how it works, but hopefully it was a way for you to learn a little more, and we look forward to working with folks again. Feel free to follow up with us on our website or through email as well. And thanks to Frankie and Kim in the background for all your hard work getting this together.
And thanks to Nick.
I agree.
He was sick, but it was really great that he did. Not that we're encouraging it. Thanks, Nick.
Thank you, Nick.
Thanks. I guess we can all sign off now. So remember, just hang up your phone, and then you can disconnect from the web room here. And look for, you'll get an email in the next few days from us with all the resources and links to the recording. Thanks, everyone. I'm going to stop the recording.